Okay, so we're going to ask all three speakers to come and sit over here so everyone can just start asking you questions and torturing you. We'll see. Good. So we have like 10 extra minutes, so we'll have a good, 25 minutes to ask questions. Please go ahead.
Once again. So a question for Dr. Burwick. In your a new trial of preeclampsia rather, and anti-C5 therapy, are you doing any search for inherited or present complement regulatory protein mutations? Is that a factor, a potential factor, in a woman with preeclampsia?
You mean for enrollment in trials or eligibility?
No, in general.
Oh, just in general. We're not quite there yet. I think there's definitely a subset of patients with preeclampsia that have complement gene mutations.
Yeah.
Some of them are more clearly defined from the atypical HUS literature in terms of pathogenicity, but many variants of uncertain significance. So I know many are creating new constructs to see if these variants have functional significance, and then investigating, maybe outside of pregnancy or between pregnancies, what are their levels of their complement proteins, what is their alternative pathway activation. But we really don't know how to use that information to then, say, counsel in a subsequent pregnancy or how to manage differently in that current pregnancy. So that's the main problem. We may be able to identify that there's a complement dysregulation, but we need the clinical trials to say, okay, one for treatment, which I think we'd love to have a treatment for preeclampsia, but then also maybe prevention. And right now, I mean, the only one that we've mostly been able to safely use in pregnancy is the eculizumab, but when we look in the hematology world and nephrology world, lots of trials on novel complement inhibitors targeting different parts of the pathway, which I think would really be a big breakthrough, especially some of the sub-Q and oral therapeutics would be really fascinating.
Right. You're right, clinical trials. I also ask because as a pediatrician, it'd be great to be able to counsel the daughters of mothers with preeclampsia as to whether they have a genetic risk.
That's a big challenge for sure. Even patients that I have with atypical HUS, that we find these mutations, many of them seek out surrogacy in the next pregnancy, and then you get into testing their offspring and their siblings, but it's hard, and the genotype-phenotype correlation is not obviously 100%. The penetrance is limited.
Okay.
Some of these don't manifest until later in life, or they require a trigger to become to manifest. So we need a lot more data. I hope more people jump into the field so we could really better counsel patients with more information.
And if I may, a question for Dr. James. So Andra, how would you approach the woman with May-Thurner anatomy going into pregnancy without a DVT or with a DVT?
So with a history of a DVT, I'll talk about that first, I just would treat her like any other patient. And I think that there is some element of May-Thurner in every patient. And we have I think that's just an anatomical phenomenon. And however, I think it also gets overdiagnosed by our surgical, our interventional radiologists, and then they put in a stent, even in a patient who's had no clot. And then, so during pregnancy, in that scenario, now we have the stent in place, and I treat it like somebody with a filter or some other intravascular object. I would recommend prophylaxis. This is a data-free zone. So in the patient who has a diagnosis of May-Thurner, who's never had a clot, and who doesn't have a stent, I would tend to treat her like anybody else.
Okay, thank you.
Thank you. Go ahead, sir.
Good morning, Peter Seigen, Penn State. Thank you all for excellent presentations. Very excited to hear all of this. First, just want to mention, I'm really glad, Dr. Vaught, you're bringing attention to disparities in delivery and access to care. I live in Pennsylvania. We have over 3,000 out-of-hospital births. About half are attended by lay midwives. We don't know if they're appropriately assessing risk of these patients. And that's another access to care that I lose sleep on every night, knowing that there are people out there that are maybe hemorrhaging at home that shouldn't have. Regarding the preeclampsia, I'm glad that both of you are here to talk about this. Dr. Burwick, your presentation notably had absent discussion about antiplatelet therapy. Aspirin has been widely adopted for preeclampsia prophylaxis in these patients. What are your thoughts on the landscape of prevention? Is this a spectrum question in terms of a risk for development of preeclampsia and then development of help, or is there something else going on?
Yeah, I mean, that would be much preferred prevention, much easier than treatment. Treatment is very challenging, so I think that would definitely be the best next step would be preventive strategies. You're right, right now the main prevention we have is the low-dose aspirin, and I think there's a small reduction. I think none of us think that it's all of a sudden going to get rid of preeclampsia, so we do think that we need more than that. I don't know the effects of aspirin on the complement cascade in particular, but I think we will need a little bit more. And progress in obstetrics is pretty slow. And we've been studying aspirin for 50 years. There's been 60, 70 clinical trials with aspirin, and hopefully we can move forward to investigating and maybe adopt the hematology models of clinical trial of what we see in hematology oncology. I'm hopeful because we've seen a breakthrough in nephrology with a huge rise in clinical trials. And I think there's progress for OBGYN to see a rise in clinical trials as well.
Okay, and regarding that, so in the patients that you've studied that have developed the TMA, how many of those may have been offered preeclampsia prophylaxis? Because I don't recall reading those when reviewing the literature. Were these studies done in a situation where these patients either weren't candidates for preeclampsia prophylaxis with antithrombotics, or was it not effective, or was the sample size too small to assess?
I think in some of the studies, it's definitely now become widespread. So most of the patients, the criteria is pretty broad, where a high percentage of patients are now meeting criteria for low-dose aspirin. But you're right, a lot of the studies, it was more restricted at that time. So probably at the time, most of those studies, people were using it for like chronic hypertension, diabetes, prior preeclampsia, and that was a high-risk group. So most of those high-risk patients would have normally been on low-dose aspirin. But like I said, I think we're still every day seeing patients with severe preeclampsia despite widespread low-dose aspirin. And most of the patients we admit to the hospital with severe preeclampsia were on aspirin, and they're getting it anyway.
Thank you.
Yeah, so at the beginning, most were getting the low-dose aspirin for the one indication where it doesn't work, which is chronic hypertension, right? It doesn't prevent preeclampsia in people with chronic hypertension. Sir?
Very nice talk and stimulating, and that's why I think I have several questions, and I think we have plenty of time. Richard, very nice presentation. Do you have any comment on coagulopathy in HELP syndrome versus atypical HUS, where you don't see that, and especially the measurement of fibrinogen? Because we have seen that patients with HELP syndrome, they have moderate to severe coagulopathy with very low fibrinogen.
Yeah, it's a little bit of an atypical feature. It depends if there's bleeding. So once you add in hemorrhage, then I think you can get that sepsis, hemorrhage, acute fatty liver. I think those things are maybe more classically DIC as a complication. But anytime you have advanced HELP syndrome, obviously part of it is like how advanced are they when they present to care, how advanced is the disease. Luckily, we follow patients so closely, we intervene and we deliver so closely that we're fortunate that we could prevent the disease from getting more advanced. But we do know it can often be very fulminant in nature, and I do think you're dealing with a more severe manifestation or advanced part of the disease if you're into DIC. But most of our patients with atypical HUS, once they're resuscitated pretty quickly with blood products, fluid resuscitation, the DIC resolves fairly quickly, and then we're dealing with the kidney failure most of the time. I don't know if you have another experience with.
Yeah, I would say most of the time whenever we check a fibrinogen in a patient that has HELP, it's usually, unless it's incredibly advanced HELP syndrome or if there's some sort of bleeding from a low platelet value, that the fibrinogen is either high or high normal.
And in severe HELP syndrome postpartum, they don't get better. what's the role of plasma exchange? Because we, in our place in Parkland, immediately within 24 hours, they don't get better, we offer plasma exchange. Because there's significant coagulopathy, liver
24-hour mark.
Oh, plasma exchange. Yeah, I'm not a big fan of plasma exchange for HELP or atypical HUS, because we have to think, like, what are we treating? There's presumed autoantibodies. I mean, obviously, that's where the strongest data is when we think of, like, TTP and other diseases where we're exchanging out those.
No, I'm talking about HELP syndrome, not in atypical HUS.
But for HELP, plasma exchange.
Yeah.
I think, I know there's some studies on plasma exchange. I just think most of the data is not very strong, and it does make me wonder if it's not getting better, and what part of it is not getting better. Is it the thrombocytopenia? So basically my rule is, if the thrombocytopenia is not getting better, I'm thinking of TTP. If the liver failure is not getting better, I'm thinking of acute fatty liver. If the kidneys are not getting better, I'm thinking of atypical HUS. Then of course you think of, but I think for HELP, should get better. So that's why I think with plasma exchange, I just don't know what we're treating at that point.
I've been doing this a long time, and I think there are those, maybe obvious, and there are those cases where, well, we didn't have complement inhibitors. We didn't have plasma exchange, but we began to see people survive the HELP syndrome that was not responding with plasma exchange. So I think that until we can sort out a diagnosis, I think that's very appropriate in the patient, like you said, who has the platelet count less than 50,000. And that's actually the patient where we are calling hematology. We're saying HELP with one L.
Exactly.
And then we need some help here. And then that is very appropriate to begin the pheresis and then refine the diagnosis, because to withhold the pheresis, I think in that circumstance is to, having seen it, lose the patient. And then there were, what we learned after that there were like 10% of patients who didn't respond to pheresis who now we've learned have complementopathy that we didn't understand. I think our treatment has helped us refine what we are actually seeing, and you did a wonderful job in your talk of classifying for it. But that patient with the atypical HELP, and it's not clear what the diagnosis is, I hope we won't refrain from plasmapheresis.
I think most people will agree that plasmapheresing someone at 24 hours is extremely aggressive, and most people will not do it. You will wait a little longer, 48, 72, 96 hours or so.
The second question, Richard, is about kidney biopsy, because it seemed that you're recommending kidney biopsy for diagnosis of atypical HUS. My biggest concern is that most of the time kidney biopsy is not really diagnostic, so it does show microthrombi. You can't differentiate microthrombi of TTP from atypical HUS or just HUS. Dr. Sai and I had shown that morphologically they look similar, unless you do specific stain for fibrin, platelets, and VWF. In most places, they are not doing that, and that could delay the diagnosis and management of atypical HUS. So if you have ruled out TTP by showing ADAMTS13 is normal or not severely deficient, why can't we immediately go ahead and use eculizumab? Because one, to do a kidney biopsy, no one is going to do biopsy unless platelet count is more than 50,000. They want to transfuse platelets. We don't know the downside of giving platelet transfusion to someone who is consuming it, because we know in TTP is almost contraindicated. So you won't get the diagnosis for at least 3 to 5 days.
Yeah, you're right. I think that's an interesting area too. Kidney biopsy findings in TTP in the age of ADAMTS13. I think, and they probably need more data on that to say, okay, in patients with normal ADAMTS13, no autoantibody, versus patients with confirmed TTP, what are the differences in the kidney biopsy, and characterizing that? Because a lot of the data from the past was kind of when we combined it, we didn't have ADAMTS13. Even when in the old case series of HELP syndrome, where they say 2 to 3% of patients with HELP syndrome end up with end-stage kidney disease, no renal biopsies, right? So we were always blaming the HELP syndrome because we didn't have this information on complement and TMA. And I think we're getting that with TTP. I've definitely heard people say that's kind of an interest, and I think that's an interesting area for research. Kidney biopsy findings in those two disorders. Is it clear-cut? If it's not clear-cut, then maybe you just have to go to a trial of complement inhibition. And exactly like Dr. James was saying, that if the platelet count's below 50,000, you're right, and you have hemolysis, and it's persistent for 2 to 3 days, plasma exchange, because TTP is so life-threatening. And we've done dual therapy. It's more expensive, but we've done dual therapy with plasma exchange and eculizumab until we have clarity. Obviously, the hospital really doesn't like the cost of that, but I will do that if we're so kind of on the fence.
I think I'll leave some of my questions for Jason afterwards.
Go ahead, sir.
Hi, my question's about postpartum hemorrhage, Dr. Vaught, and particularly you went through the blood banking management and so on, which was very helpful, and massive transfusion. But in terms of the details of the hemostatic measurement, I sort of wanted to return to an old discussion, which was that of recombinant factor 7A. And it seems to me that the Europeans have a different view of it. I know it was being considered for this indication by the EMA last year, and their guidelines tend to be a little bit more liberal. You know, the various societies in the UK and also in Europe. I'm not advocating for it. I'm just asking you, you know, where is it fitting in now in the US? Is the practice diverging from the European practice of using 7A?
So I would say in clinical practice, and again, you know, as Dr. James would say, it's becoming more of a data-free zone in ultra transfusion, but recombinant factor 7A really is a kind of like a Hail Mary kind of. You've kind of done everything, and you're really trying to just do what you can. I will say that, you know, postpartum hemorrhage and massive transfusion and all of these things are increased risk of thrombosis in the postoperative period. I think the 2 or 3 times I've ever, as a trainee attending and as a fellow, seen recombinant factor 7A used in that situation, there is usually some form of thrombosis that occurs.
It's not been my experience, I have to say, but, you know, and I think that you are using it too late, perhaps, when you're at that. And I, you know, I don't know how we're going to get at this. Mostly the European studies are based on propensity matching scores and that kind of thing. I don't know that there'll ever be a proper trial of this. But the other question I guess I'd have would be, you know, fibrinogen targets. There's been a lot of work on, again, Europeans are a little bit different. They use fibrinogen concentrates in many countries. And there's been quite a bit of data on, you know, fibrinogen. Certainly, I don't know whether 200 is what you recommend or whatever, but again, I just wanted to hear your view on it. But.
That is actually something where I would love to see both clinical and research data go as far as postpartum hemorrhage. We know that, especially for patients that have abrupt placental abruptions, that their fibrinogen can become quite low quite quickly. In a lot of postpartum hemorrhage, when someone gets labs during the resuscitation, there's noted, you know, not only low fibrinogen on ROTEM tags, increased fibrinolysis, which is kind of where the TXA use and woman trial kind of came into play. But I do think that there really is a space in postpartum hemorrhage for the use of fibrinogen concentrate. Thawing cryoprecipitate, you know, is time consuming, can take 30 minutes on the blood bank's best day. You know what I mean? 45 minutes to an hour on a normal day. You know, if you're in a procreta and you're hemorrhaging, or if you're in a really bad atonic uterus and you're hemorrhaging, you know, 30, 45 minutes in, one, hopefully your case is, you know, the uterus is out and your case is coming to an end, but also, two, you're probably 8-9 liters in by then. So I do think that, like, that is something where I would be very excited something I'm very excited to see.
Thank you. Dr. Peters?
Great. I have a whole different list of questions now, but I'm going to be very quick. One, I completely agree with Nigel about recombinant 7A. We published this largest single center experience, and Andy knows this, with Nazli Hussain out of Karachi, where the recombinant 7A was actually life-saving. They didn't have other therapies. And my comment about this is that the 70 mics per kilo, the dosing, what they used in orthopedics, is far too high than what we need. And that if we use, this is like my opinion about this, if we use a lower dose, half it at least, and maybe once, I think we're gonna, we'll cut down and limit the thrombotic thing. So I think it's definitely not first line, but we shouldn't waste it. I think there's a good utility for that. That's my first. The second, on the fibrinogen, look at all the data that we have from Peter Collins and the other Danish studies about fibrinogen replacement. So in postpartum hemorrhage, the Danes in the perfect PPH study, they showed, first of all, the fibrinogen levels, they're physiologic, basically for what we need. And in the mild case, you never get down to low enough levels where the replacement makes a difference. And secondly, in the severe cases where they actually had to use multi-center trials to really get down to it, you had to have pretty massive hemorrhage before you saw any change with utility for it, actually, and the endpoints being replacement therapy. So I, like you, because I started with trying to look at fibrinogen concentrate for PPH, but saw all this data and said, leave it, and then sort of gravitated to thinking about it for the accreta space, which is, an evolving area. But I think it's a treatment where we're looking for an indication. My comment about you asked about the outcomes for the Ultra MTP. I think a great space would be, let's look at our accreta data. It's published, and we can get that outcome for you to find out about the morbidities. Maybe we can call the investigators to look at all of that. So, in terms of trying to understand outcomes. And then, well, go ahead.
Oh, no, I said that would be great.
Yeah. And then, so for Richard, awesome job. Two quick questions. The C5, the data, are the elevations in the blood occurring in the severe preeclamptics you showed, are they superimposed or superimposed and so I'm trying to get to the idea of, is chronic hypertension part of that space? Because from a trialist perspective, if I were going back to preeclampsia, I would try to use a pure phenotype, even nullip ideally, but and not chronic, to really get at whether it prevents it. So, any idea?
Yeah, we don't know when their elevations start. I mean, we do see, right, in blood, the C5b9 and C5a, so that terminal pathway, it's elevated in chronic hypertension, gestational hypertension, and all forms of preeclampsia. So we couldn't really differentiate. We couldn't even get a cut point in plasma. So that's why, but urine, it's not there in urine in hypertension or mild preeclampsia. So that was, for us, a better marker. But I think you're seeing, they're predisposed to preeclampsia. Could be because their complement activation is increased. And we don't know when that starts. But perhaps, we know aspirin doesn't work in chronic hypertension. We had that same experience, no benefit in presumably the highest risk group. Aspirin is not preventing preeclampsia. So that could be, if you had patients with chronic hypertension, elevated complement pathway, that would be a potential for a clinical trial.
Will it drive the S-FLT levels down? Because I think that's paramount for preeclampsia treatment.
Well, that's to be determined. I mean, there's case reports. There was a case study out of Australia where they had a patient with preeclampsia. No. I think atypical HUS, then developed preeclampsia, I think, on top of it. I forget the details of the case. They then treated with eculizumab, and the S-FLT levels came down, and they were able to kind of expectantly manage the pregnancy. That patient had a dual diagnosis of preeclampsia and atypical HUS, and it was the S-FLT levels came down once the complement inhibitor was started. There's some data in animal models that's possible, but very little human data, I think, at this point.
Thank you.
All right. I know you have questions, sir. They'll be happy to answer, but we're right at 9:30. I just have a 10-second question to you, Andy. Yes or no? Someone, let's say at 32 weeks, pregnant, comes in with shortness of breath, some palpitations, had some chest pain, get a D-dimer less than 500 nanograms per ml, so negative. Do you send her home or you get a CT angio?
CT angiogram.
All right, thank you.